Dr. Oregon, so now we repeat the report the questions. Yeah. So 35-year-old woman received the breast conserving surgery stage 2 and 0, TC 4 cycles, and the radiation and endocrine therapy with the GnRH. This is free the interval 1 year, recorded with a small liver mass biopsy liver revealed ER/PR positive, HER2 negative, Ki67 high. So please vote. Which agent is preferred in this patients? Premenopausal woman, T2 and 0, recorded 1 year, still ER positive. Yeah. Most of the audience seems to move to ribociclib after the talk. Two-thirds, then 70, almost 80%. The second question is if progressive disease after long-term duration of a treatment occurred, can we consider a switch to new endocrine therapy and new CDK46 inhibitor? We heard the PACE study and the maintain trial. Yeah, more audience voting for yes. Third question, as a 40-year-old woman presented with the left breast mass 4 centimeters in size and palpable and fixed lymph node. Clinical stage T2 and 2, stage 3A. Biopsy of breast mass revealed ER/PR positive, HER2 negative, Ki67 high. Lymph node was consistent with the metastatic lymph node. AST, ALT elevation, and the CT scan revealed multiple extensive liver, lung, bone mets. De novo case, premenopausal woman, extensive metastasis was. She was presented with extensive metastasis, de novo. Yeah. The rate is almost similar to the previous one. So we'll have a Q&A. This topic is open for the Q&A and any comments. I have a question to Dr. Regan. So when this 3AI is came out, we have this kind of discussion. So are they similar or different? You mentioned of the IC50 is somewhat different among 3 CDK46 inhibitor. So like the AI, intracellular aromatase inhibition is different, but clinical efficacy is similar. So if the CDK4 selective inhibition is crucial, why there is no difference in terms of PFS, although there is a difference in terms of overall survival? How do you explain that?
Well, I mean, it's hard to explain, I'll admit that. And I think, Deb will probably want to comment on this as well, just in terms of some of the limitations of the Paloma study. But I think it's more than that. I mean, there's difference in the adjuvant setting in terms of the trials as well, but, I mean, they're quite different results, right? And so I think that overall, I actually was a discussant on 2 years ago on the adjuvant CDK inhibitor trials, and the last thing I thought I would ever say is that they're different, but I do think there are some differences, and whether it's because of the affinity for CDK46 or not, I don't know the answer to that, but I think we also know the toxicity profiles are different as well, but I'll let Deb comment on that as well.
Okay. And Deb, then.
On specifically the variability that we see in the hazard ratios of PFS and OS, well, as I mentioned on the Paloma 2 study, which was just presented at ASCO, I think that there's a disproportionate number of people that fell off. And if you look at the data that we do have, which again, cross-trial comparisons are problematic, and it's hard to draw conclusions from them. It's hard to draw conclusions from post hoc analysis, But when we look at the patients that remain on treatment from PALOMA-2, we see that that proportion is much higher in the patients on the palbociclib and letrozole arm. So given the imperfect world that we're in, where there are limited data, I think that that trial isn't going to tell us all the things that we want to learn. And so that might represent some of the reasons why there's discordance between the hazard ratios of PFS and OS.
I will say, I think just because you brought up the aromatase inhibitors, when they were compared adjuvantly, they were the same. So it's somewhat of a different world, I think. So.
Okay. Microphones 3? Yeah.
Yes, this is Jessica Jones. I'm UT Health Houston. I have a question regarding germline mutations. So looking at the data that you presented for all 3 trials, especially looking at the premenopausal women and knowing that we're moving to more personalized treatment, incorporating genetics, what are your thoughts about ATM check2 mutations, especially in these premenopausal women? And do you see any value to doing subgroup analyses within the trials that you presented? Thank you.
Yeah, I'll comment on that. There's actually a really nice publication in JCO Precision Oncology from this last year. Debu Tripathi might be the first author on it, but looking at this very question, trying to look and understand some of the next generation sequencing patterns that we see and how that correlates with efficacy in these therapies, and they do draw some conclusions about that. I believe the paper was with ribociclib, but it's from JCO Precision Oncology from this last year. I think that that's a really interesting area of investigation that we should understand better, and as we're all doing next generation sequencing on patients with advanced cancer, that we should be able to aggregate that information and make more conclusions as data emerges.
No, I think absolutely. The other thing I think that comes up, and I'd be interested in your thoughts on this, is, if you have somebody in the early stage setting who is high risk enough to qualify for a BEMA, but has a BRCA mutation, what do you do for that patient in the adjuvant setting?
I'm sorry, if they're in the adjuvant
So
setting
they've
and
got a
they're
BRCA
high risk?
mutation, they're high risk, and they've got a BRCA mutation. So you're deciding between olaparib or a BEMA.
I think the best evidence that we have right now is to give the patient BRCA-specific therapy with olaparib, and that's my therapeutic choice. But again, over time, our understanding of the benefits might change. But I think today, that clear answer is olaparib.
Yeah, and I think it's probably, could be easier to tolerate as well. I mean, I think a BEMA can be very challenging in the adjuvant setting in terms of toxicity.
Microphone 2. Yeah.
Hi, I'm Felipe Battalini from Mayo Clinic in Arizona. The fact that the progression-free survival is very similar and the overall survival is different, to me suggests there's something that is happening after that could be causing the difference. Do you have any insight on mechanisms of resistance between the 2 drugs to see whether the progression is different and the makeup of the tumor heterogeneity is different upon progression of the 2 different drugs?
It's a really great question, and I think that was certainly something that we were concerned about initially. Is if you stop the CDK inhibitors, that the cancers seem to behave more aggressively. I'm not aware of at least any kind of translational data showing differences, or that anybody's actually looked, post each compared them tumors after they come off that I'm aware of. And preclinically, I haven't really seen anything either. But it's a very good question for sure. I don't know about you, the 2 of you. Have you seen anything?
I think they're good questions. I don't know a good answer to that question. Again, I think that, when we're in the scenario like we are today, we're going to try to draw a lot of conclusions and extrapolations on data we don't have. It's a data-free zone. And so I think that the best thing that we can do to help our patients is draw the best conclusions we can on the data we do have and continue to investigate. And I think that, like many things in medicine, 5 years from now, we'll look back and just know a whole lot more. Until then, we're postulating.
Any questions? The questions from the... So the question from the audience is that which CDK460 inhibitor has data on stimulating anti-tumor immunity? So which CDK460 is more better in terms of stimulating anti-tumor immunity?
I don't think we know the answer to that, but I think, we have data that was presented this morning showing that, with palbociclib, using a checkpoint inhibitor appears to actually really help some patients. So I think, there is data saying that they do, impact the immune milieu of the cancer cells, but I don't know that we know that one is better than another in that scenario. I think that's the first data we've seen with CDK inhibitors and checkpoint inhibitor as far as I know. I know there are other ongoing trials as well.
We already discussed the small phases 2 trials, the PACE and the maintain trials. So based on these trials, so is it okay to really justify to give CDK460 inhibitor beyond the progression in clinical practice?
I think let's look at the differences in the MAINTAIN trial that was presented at ASCO versus the PACE trial. In the MAINTAIN trial, patients received ribociclib, and most of those patients, by the nature of the beast, were treated with palbociclib beforehand because it was approved 2 years beforehand, so they switched CDK46 inhibitors. Whereas, and that was a positive trial showing some benefits, showing that would be a reasonable therapeutic option to switch to ribociclib. So is the difference then switching between CDK4/6 inhibitors, or is the difference switching to ribociclib? And I think that we don't know the answer to that question. I imagine we will over time as we, continue to look at the trials that are have not yet reported, and also, real-world evidence in this space. I think that we'll learn a lot. But the best evidence that we have for retreatment right now is in patients that were previously treated, then treating them with ribociclib.
I think it's a great question, though, because, I think we clearly saw from the polls that a lot of people are using ribociclib now first line, and I think the PACE study would suggest that continuing the same CDK inhibitor probably isn't a great idea. So, so I think that's kind of where we're at. So, I don't know if we switch from ribo to palbo, that might be beneficial. We just don't know. It's, as you said, it's the data-free zone.
Microphone full.
Yeah, this is Carlos Artiaga, and this is a question for Dr. O'Regan. In our spirit to try to find even more differences, if there are any. Does the difference in IC50 to the different CDK4 suggest that there may be an opportunity that is greater for one versus the other to reduce the dose and still maintain the same biochemical efficacy?
That's a great question. So I think, we have a lot of data saying that if you dose reduce in some of the studies that the efficacy is maintained. So I think that's a really good question, because I think with some of these drugs, the toxicity is really problematic. And, I think we were talking about adjuvant abemaciclib a few times during the meeting, and, should we be dose escalating that so patients can tolerate it? So I think that's a great question, and it'd be definitely worthwhile. Maybe you can look at it in your lab, right?
Yeah, well, no, I think it has to be done in probably people.
Yeah.
But the other thing is, we are learning of new agents, like we heard of AKT pathway inhibitor today, and there are going to be other pathway inhibitors that are going to be partnering with fulvestrant or with SERDs. And we're going to have a number of SERDs to combine them with probably. So there may be another opportunity for differentiation, right? It may be that in some cases, because of additive toxicities or additive pharmacokinetics that need to be discovered, some may be more combinable than others with this or with that other SERD.
Yeah.
So, but
totally
are we
agree.
at a point, can I challenge you to select what will be your ideal of the three to partner with the new SERDs? Or can you commit to identifying one?
I off the top of my, I guess since there's some GI toxicity with the SERDs, maybe you don't want to use a BEMA. But again, it's diarrhea, not nausea and vomiting. So I don't actually know. I think we're going to see data with all of them. And, I think obviously what we're seeing is whatever company's making the third, it's usually their CDK inhibitor. So, I think we'll find out. I don't know if you have any thoughts about that, Deb, which would be the winner one there.
I think we'll see trials with all of them. I don't have a sense for that.
Last question, quick question, microphone 3.
Lucian Berwicz, Warsaw, Poland. Thank you for your comprehensive lectures. Of course, these are completely different chemical entities. They have very similar progression-free survival, and we don't continue them beyond progression. So probably the overall survival will be, in general, the same. The only question is about the patient tolerance. If you are here in this room, it's better to have neutropenia rather than diarrhea. And your patients experience different reported outcomes, but we don't test them. Probably we should initiate the real-world initiative with the same inclusion criteria, that all of us will select our best choices which we want to have, giving the patient the same patient-reported outcomes measures, and summarize it in 1 month, but globally, not a clinical study. Do the same registry, and in 1 month you will have the answer, what is the patient's preference. Thank you.
I think it's a great point that you make. As Dr. Hayes said right before this discussion, we want to have patients live longer and better. And really the beauty of bringing these drugs to patients is that they can live a long time without being on chemotherapy and have their disease controlled and have a good quality of life, live their life, work or sit at their dinner table or take their kids to soccer or sleep next to their spouse, be themselves. And that's amazing. And so your point is a great one. Now, there are data looking at older populations, looking at quality of life in these agents that are very favorable, but more work does need to be done, and on a broader scale. I will say I think we have that capability. We particularly have that capability as the EOM will launch from CMMI. Many of us will be incorporating patient-reported outcomes instruments in our daily practice in a more robust way. And I think that real-world evidence will be out there. It will be a great time to make those comparisons to make sure we're all still making choices to optimize our patients' quality.
Last question, microphone 4.
My question is pertaining to bone-only metastases in metastatic breast cancer who are treated with CDK46 inhibitors. Even in the registration trials, it was not very strictly allowed to get bone imaging done to see response evaluation and see progression of disease. Now, with these SERDs coming up and the time frames of 6 months, 12 months, and 18 months being so very important, how do you propose that we assess the bone-only disease to mark progression of disease and change therapy?
You want to take that? You want to take it? No. I think, bring up it's one of our challenges, right, is monitoring bone mets for sure. So, I think typically, we do bone scans and CTs. I think some people do PET scans, but it is very challenging for sure. With the SERDs, I think it was brought up today is, I think one of the entities that might be useful is FES PET, which now, is approved. So that's something that we might use, and because that would help you see as well if the drug is hitting its target, since they cause downregulation of ER, or it should. But I think it's a challenge, and I think, that's something. If we had a better test, it would be great. I don't know if you've got anything to say.
Because of time limit, we need to close this session. Thank you very much, Dr. Pat and Dr. Oregon, and an excellent talk and active participation from the audience. I'd like to close the session. Next session is the plenary session. Thank you.